Thank you all for joining us today. Today we are going to discuss on LGBTQIA+. We have an eminent faculty joined here for walking us through that session. That is Dr. L. Ramakrishnan. Welcome you, sir, and thank you for being here. And for further session facilitation and faculty introduction, I invite our facilitator, Mr. Sharat K.
Thank you, Sinia. So I think everyone is very well at their own places. So as continuation to our last session, so today we have a new session which is being presented by Dr. L. Ramakrishnan. As you all are well aware of him, he is the Vice President of SATI, Solidarity and Action Against HIV Infection in India. So he will be the person who will guide us through this very important and interesting topic. He earned his doctorate in 2000 from the University of Texas at Austin, USA, and he has gone through so much very decorated fields. And he worked in health and human rights non-profit settings in USA and India. And you can go on; you can just go through his entire history. And he is such a humble person, and I know his sessions previously, and he will guide us through a lot. And over to you, sir, and welcome to the session. And a large part of your information will be grateful for us in this session. Over to you, sir.
Yeah, thank you so much. Am I audible?
Yes, sir.
Yes, you are, sir.
Unfortunately, my camera is not coming on. I hope at least my PowerPoint will. Can you tell me if the PowerPoint is coming on?
Yes, sir. Your PowerPoint is visible.
Okay. Okay.
It's
Great.
perfect now, sir.
Okay, great. Yes, it's always a pleasure to be back with the Pallium India, and I think this may be the third or fourth session that I've had the pleasure of doing, and it's always been quite an enriching and learning experience for me and a good discussion overall. So what I will be talking about today is palliative care in the context of the LGBTIQA communities, which is lesbian, gay, bisexual, transgender, intersex, queer, and asexual. And a lot of people may have heard certain terms. You may have heard of gay and lesbian, you may have heard of transgender, you may not have heard of intersex, etc. So I'm going to do a quick overview of concepts and then speak about why we are here, which is somebody belonging to the LGBTIQA community faces a lot of stressors, mental health stressors that have an impact. So we'll be looking at the mental health impact of being of a different gender or sexuality in a context where most of the world is what we call patriarchal and cis and heteronormative. We'll talk about how family, society, and health care settings view LGBTIQA persons, a little bit about the legal issues, and then I'd like to focus on the barriers community members have in accessing palliative care, and I'd like to go through a few best practices. Okay, so I continue to be audible and the screen visible, right?
Yes, sir.
Okay. So when we talk about LGBTQIA, you can broadly classify these into three areas. One is pertaining to sexuality, one pertaining to gender, and one pertaining to sex characteristics. So I'm going to unpack all of these. When we talk about sexuality, we actually have three subcomponents. One is sexual orientation, which is who someone is attracted to, sexual behavior, who someone has sexual relations with, and sexual identity, which is how a person identifies with respect to their sexuality. And so these are depicted here by three overlapping circles to make the point that the three of them are not always congruent with each other. And let me work through this with an example. So sexual orientation is who someone is attracted to. So typically we say that if a man is attracted only to other men, such a person is homosexual or gay. If a man is attracted only to women or a woman is attracted only to men, we say that they are heterosexual, or the common term is straight, and so on. So you have terms like homosexual, heterosexual, bisexual, asexual, etc. Then we have who someone has sexual behavior with or sexual interaction with. So imagine a woman who is lesbian. So she's a woman who's only attracted to other women, but she is brought up in a community, a family, in a society that does not approve of people being lesbian, being attracted to other women and acting on that attraction. So she is coercively married off to a man by her parents. And so she's forced to get married to a guy and to have sex with him. So in such a situation, her sexual orientation is focused on women, but her sexual behavior, because she is non-consensually married off to a man, maybe her sexual behavior may be only with that man. And similarly, depending on how open or closed that community is, she may not have the luxury of identifying herself as a lesbian. She may be forced to identify herself as heterosexual because of family pressures and societal pressures. So if a person's orientation and behavior are completely overlapping, so for example, a man who's attracted only to women and is in a relationship with women and having sexual interaction only with women, then those two circles will be congruent. Otherwise, there will be some part of the circle that is not overlapping. So let's again look at these terms, orientation, behavior, in a little more detail. So we have terms, these are common terms you may have heard of. For example, if a man is primarily attracted to other men, and sometimes women also use this term, if they are primarily attracted to other women, the term is gay, but it's often more common for a woman who is primarily attracted to other women to use the term lesbian. So gay is sort of a gender neutral term, but tends to be used more by men. Lesbian is a gender specific term, tends to be used by women. Bisexual is referring to a person who is attracted to more than one gender, but not necessarily 50-50, equally. A person can be more attracted to one gender, but still significantly attracted to another gender, and bisexual would still be an acceptable term. Heterosexual or straight is an identity corresponding to primary or exclusive attraction to a different gender. So a woman attracted to men, a man attracted to women primarily would be heterosexual. Pansexual is a related term to bisexual, but it refers to people who are attracted to other people independent of gender. So you have people who say, oh, it doesn't matter to me what their gender is. I'm attracted to other traits of theirs. I'm attracted to their intellect. I'm attracted to their wit. I'm attracted to their charisma. I'm attracted to their kindness, whatever. So pansexual often is a term used by people who feel that their attraction transcends gender. Asexual is a person who is not significantly sexually attracted to anyone else. And the thing to note here is asexuality doesn't necessarily mean that they are not having sex. It means it's talking about orientation and not about behavior. So if a person is not having sex deliberately with other people, such a person will be called celibate. So celibacy is about behavior, but asexuality is about sexual orientation. And again, asexuality may coexist with lack of romantic attraction, or it may be accompanied by romantic attraction. So for example, if a woman says she's heteroromantic asexual, it means that she's not sexually attracted to anyone, but she may be romantically attracted to men. And similarly, let's say you have a homoromantic asexual. This would be a woman who's attracted to other women romantically, but not sexually. There are also people who refer to themselves as aromantic asexual, which means that they are not romantically or sexually attracted to anyone. And that term is often abbreviated to aro-ace. So ACE is an abbreviation for asexual. Then you see the term queer often used, and queer tends to be used as an umbrella term. So somebody who's gay, bisexual, heterosexual, lesbian, pansexual, asexual, sometimes looks for an umbrella term to say they are part of this community, which is outside the mainstream. And such a term is queer. Also, one thing to remember is sometimes sexuality is not fixed. So a person may be attracted to one gender at certain part of their life and may be attracted to another gender in a different part of their life. So this would be called sexual fluidity, or it may be called sequential bisexuality. So these are all terms that are identities corresponding to certain orientations. So term gay is an identity corresponding to a predominantly same gender orientation. Okay. And all of this is related to who you're attracted to. They are not related to your own gender, which we'll be talking about in the context of gender identity. So terms like L, G, B, and A for asexual are all terms related to sexual orientation. On the other hand, if we are talking about gender, we actually have two concepts of gender here. One is, like many of you who have trained in the social sciences would have heard that, sex is biological and gender is social. So this is partially but not completely correct. In general, and we're going with the World Health Organization definition here, gender refers to socially constructed roles, behaviors, activities, and attributes that a given society considers appropriate for men and women. So let's just go with discussing gender a little bit. So let's say a child is born with male body parts. The doctor will say it's a boy when delivering the child, and the family will bring up this child as a boy and raise this child to be a man. So being a boy and growing up to be an adult, a man, comes with it, brings with it a lot of social expectations. So can someone here unmute and share what are some of the expectations associated with being a boy? Anyone?
You don't show emotional vulnerability.
Okay, don't show emotional vulnerability. Fantastic. What else? Anyone else? Yeah.
Breadwinner.
Breadwinner. Okay, excellent. Yes, and for women, they are expected to be, or to show, it's okay if they show vulnerability. It's okay if they are emotional. They are expected not to be aggressive. If a woman is assertive in the workplace, that same assertiveness is maybe accepted if it's in a man, but if it's in a woman, they would call her aggressive or something like that. So there are all these expectations. And as a child growing up, boys are expected to be active, interested in certain kinds of sports, running around, climbing trees, getting hurt, whatever. Women are expected to be, or girls are expected to be interested in more domestic activities, playing with dolls, playing with cooking toys, etc. So there are a lot of these expectations, and some of these expectations also have to do with clothing. So while shirt and a pant may be gender neutral or getting fairly gender neutral over time, a skirt would be, or a sari would be, exclusively the domain of women. So gender can also be about how you express your gender in terms of clothing, or in terms of your figures of speech, how you walk, how aggressive you are, how assertive you are, how compliant you are, etc. So any person who is not conforming to what society expects. So a child who is biologically male, but it has no interest in playing cricket, would rather sit in the classroom and read a book or play with other girls, is called, is taunted as being effeminate or being a sissy or being a girl. And such children are subjected to teasing. Sometimes this may escalate to harassment, including sexual harassment and violence. So gender here is often variable by society. So wearing a skirt may be seen as not a masculine trait, but maybe if you go to Scotland, wearing a kilt is perfectly acceptable for a man. So some of these may be variable, but things like boys don't cry tend to be kind of universal gender expectations of what a boy or a man should be doing and what a girl should be doing and not doing. Now, apart from the social component of gender, there is also an individually felt internal sense of gender, which is distinguished from the social part through the term identity. So gender identity is defined by the American Psychiatric Association as a person's deeply felt inherent sense of being a boy, a man or male, or a girl, a woman or female, or feeling like they belong to neither camp, or feeling they belong to both camps. And gender identity may or may not correspond to the social gender, which is typically assigned based on the person's sex. So let me describe this in a little bit of detail. Imagine that a person is born with female body parts, is born with a vulva, and at birth is pronounced by the doctor delivering, saying it's a girl. So the society and the parents raise this child to be a girl, but the child feels very strongly internally that I'm not a girl, I'm a boy. And such a feeling may arise quite early in the life, even much before puberty, even as early as 2 or 3 years of age. And this is, so here we say that the child has a gender identity which is different from the socially assigned gender. The socially assigned gender is based on the biological sex, which is determined at birth or assigned at birth. Okay, so if a person has a gender identity which is different from the socially assigned gender, then the person is said to be transgender. If the person's gender identity is concordant or conforming to the socially assigned gender, then the person is called cisgender. So here we go. Transgender is gender identity contrary to gender assigned at birth, which in turn is based on biological sex. So a child born with a vulva is assigned the female sex, and a child who is assigned female sex and brought up as a female gender, as a girl, feels internally that they are a boy, then such a child would be trans. Similarly, you may have a child assigned male at birth who thinks of themselves as a girl, and that child would also be trans. And the biological sex part itself at birth, typically just based on whether the child is born with a penis and scrotum or a vulva. But actually, there are more aspects to sex, like what chromosomes you have, what are your internal body parts, and we'll get to that in just a bit. For right now, let's just say that transgender is a person whose gender identity is different from the gender or socially assigned gender, which itself is based on biological sex. So most of the people in this room are what I would assume to be cisgender. So a person who is not transgender is cisgender. And the term cisgender and transgender were coined, had their roots actually in organic chemistry, where you refer to molecules as cis or trans. So if any of you have had a science background, these terms may resonate with you. Now, even within trans, there's quite a diversity of transgender identities. Going back to the person who is assigned female at birth, but who identifies as not female, if that child identifies as male, this person would be a trans boy or a trans man. And trans man is one of the binary transgender identities. That is, you're identifying with a gender opposite of the socially assigned gender. So a trans woman would be somebody born with male anatomy, assigned a boy at birth, but who identifies as a woman. A trans man or a trans boy is assigned female at birth, but identifies as a boy or a man. Both of these are binary identities because you're identifying with the quote unquote opposite gender. But you may also have a non-binary identity where a person does not identify as what they were assigned at birth. They may say, I'm not a girl, but they may say, I'm not necessarily a boy either. So such a person may identify as non-binary or androgynous. And so you have, within the trans community, you have binary trans people who are basically trans men or trans women. And then you have non-binary trans people. One important thing, earlier to this, we discussed slides pertaining to whom someone is attracted to, which is sexual orientation. An important thing to remember here is gender identity is not necessarily connected with sexual orientation. So you may have a person who is assigned male at birth, who is transgender and who identifies as a woman. But while many such people may be attracted to men, it's quite possible for a trans woman to be attracted to other women or other trans women. So in which case they may identify themselves as trans lesbian. Similarly, you may have a trans man who is assigned female at birth, but has a gender identity of a boy, but who is attracted to other boys. So you cannot really conclude a person's sexual orientation from gender identity or vice versa. Someone has raised their hand. Please go ahead. I saw that somebody raised their hand.
Isha, you want to communicate something or? Very feeble, very feeble.
Am I audible now?
No, I think
I
there
can't.
is, yes, yes, very feeble.
Still very soft.
Yes, yes, now it is clear. You can continue.
When you say transgender man,
Yeah.
You mean, is he a biological man or not?
No, I mean, so transgender man refers to their gender identity as a man who is transgender because they were assigned
Okay.
female at birth.
Thank you.
Any other questions? Yeah. So just like the majority of population on Earth is heterosexual, that 90% of the population is men attracted to women and vice versa. And about 10% are attracted to the same gender or to both genders. This is kind of a rough estimate. Similarly, within the trans community also, while a majority may be heterosexual, you have about 10% that is homosexual or bisexual or asexual. So in other words, a trans woman, there's about a 10% chance the trans woman is actually a trans lesbian. Similarly, there's about a 10% chance that a trans man is trans gay man, meaning that that person was assigned female at birth, but identifies as a man and is attracted to other men. Okay, so gender identity and sexual orientation are not the same thing. And this is very important because very often when you read even the media reports these days, even yesterday, there was an article about some crisis that happened in Uttar Pradesh, where they said a girl changed her sex in order to marry another girl. So this is completely wrong. The way of thinking, you do not actually change your sex to marry another person. You change your sex because you are uncomfortable in the body you were born with. So a person who has changed their sex may not necessarily be interested in, a female assigned person who changes sex and identifies as a man may not necessarily be attracted to women. They may be attracted to men or to multiple genders or to no gender. So sexual orientation and gender identity are different from each other. And just like we saw sexual identities like gay, lesbian, bisexual, there are transgender identities. And in India, we have terms like hijra and kinnar that many of you may be familiar with in the Hindi-speaking part of the country. Nupi Manbi is a term for trans women in Manipuri, in Meitei. There's also a term Nupa Manba for trans men in Meitei, in Manipuri. Tirunanga is a term from Tamil for a trans woman. Tirunambi is a term in Tamil for trans man. There are other terms like gender fluid, agender, non-binary, etc. So there are a lot of terms. Now, you will notice that there are a lot of terms for transgender people in Indian languages other than English. But for terms like gay, lesbian, bisexual, typically there are not that many Indian language terms. There are terms like samlangik that have been coined. But typically in our culture, there are more terms for transgender than for gay, lesbian, and bisexual people. There is one reason for that often trans people are more visible than people who are not trans, but who are cis, gay, lesbian, bisexual. So they're not so visible. And because of the way society is structured in a patriarchal way, where only heterosexual orientation is approved of, many people do not come out and disclose their sexual orientation. But it's much harder to hide your transgender identity. So because of this, in Indian society, trans people are often more visible than gay, lesbian, bisexual people. This results in two problems when we are talking about palliative care, etc. If you're talking about an elderly person who's transgender, it may be more obvious that they are transgender. But a person may be, a single person and an old person. That person, we don't know if that person is single because they are gay and they haven't found a partner of the same gender, or that they are asexual, or they simply did not find a partner of the opposite gender, or they are single because they do not want to disclose their sexual orientation. So sometimes it becomes very difficult, and especially if you're talking to somebody who's of a generation where they are 50 or 60 years of age. They grew up in a time when being of a different sexual orientation was very much frowned upon. So if you are a palliative care provider and you're speaking to a client who is single, don't make any assumptions that that person is, had a love failure, but had a partner of the other gender. It could be that person was gay or lesbian. It could be that that person was asexual. It could be any number of reasons. So you have to explore that in a very cautious and a very sensitive way. And we'll discuss that a little more as we go forward. Now, I'm just going to quickly try to get my video back on. I'm just thinking there may be a reason. Just give me 1 second. Yeah, I think my picture's come. Yeah. So this was about transgender. You can still see my slides, right? Yeah, okay. Now, just like we talked about gender and gender identity, there is a term called gender expression. When we talked about, for example, a 2-year-old or a 3-year-old child that is a male assigned child, but who behaves in a feminine manner, right? That the behaving in a feminine manner is what we call gender expression. Such a child may not have the awareness or consciousness that they are actually transgender. But at the same time, the way the child expresses themselves naturally may result in teasing and bullying. So gender expression could be through hand gestures. It could be through the way the eyebrows move. It could be through the pitch of the voice. It could be through, choice of dress, choice of makeup, etc., etc. So, and again, this may be socially variable and culturally variable. But the point is that someone may have a gender expression which is different from the norm and may be teased or ridiculed for it, because a non-conforming gender expression is often used by the public to infer that the person is gay or transgender. So if a child is male assigned and behaves in a feminine way, other people may think, okay, this child is growing up to be transgender, or this child is growing up to be gay. But these are all inferences made by other people, whereas what you're seeing is just a gender expression that does not conform to the norm. And it's risky to impute or make assumptions about the person's sexuality or identity just based on their gender expression, because there may be heterosexual women who prefer to wear their hair short, who speak in a deeper voice, who may prefer to wear, so-called masculine clothing. It doesn't necessarily mean they are trans men, doesn't necessarily mean they are lesbians. So one has to be cautious while inferring somebody's gender or sexuality from how they express their gender. So a person who does not conform to social expectations of how gender is expressed is called gender non-conforming. So a point here, an individual whose gender expression is not aligned with the gender expected of them based on assigned sex is gender non-conforming. Now, if this person's gender identity is also different, then you will say the person is transgender. So gender non-conforming is often a term used for children whose behavior or play or expression is viewed as different from what is expected. But such a child, when a child grows up as an adult, may identify as trans, may identify as heterosexual, may identify as gay, lesbian, bisexual, or asexual. So one cannot necessarily predict adult gender identity or sexual orientation from childhood gender non-conformity. However, many in the LGBT communities report being gender non-conforming as children. So look at it as two different things. There's a group of gender non-conforming children. They may grow up to be of any gender or sexuality, including trans, including heterosexual, including gay, lesbian, bisexual, including gender non-binary, including asexual. But if you ask the people who are adult and who are from the LGBT community, you'll find that many of them have recall that they were gender non-conforming as children and got teased as children. So the important thing to remember is gender non-conformity is not an identity. A child as young as 2 or 3 may be gender non-conforming without having any sense of its gender or sexuality. Now, I will be playing a video later on. So the thing to keep in mind is that a child who is gender non-conforming may or may not grow up to be transgender. But there are certain cases where a child is gender non-conforming, but also expresses a deep disgust with their body parts. Okay, they feel, I don't want a penis, or I don't want to develop breasts. And such children, the kind of discomfort they feel with their body is something called gender dysphoria. So gender dysphoria is acute discomfort with the biological sex and the assigned gender. It's may or may not be accompanied by a desire to change one's body. But many people with gender dysphoria do choose when they grow up to, change their body, have surgery, take hormones. So for example, a child who is assigned female at birth may be gender non-conforming, behaving in a boyish manner, a tomboyish manner. But if a child like this is also gender dysphoric, meaning not only is the child behaving like a boy, but appears to be acutely ashamed with their own body parts and wants to have a penis, such a child is said to be gender dysphoric, and such a child is more likely to grow up to be transgender and to desire male hormones and desire surgery for removal of breasts, etc. So there are terms that, for example, the World Health Organization has a medical term called gender incongruence, which is a new term. Since last year, we've had this term called gender incongruence. Before that, the term was gender identity disorder. So now actually the current medical opinion is that having a different gender identity is not a disorder, which is why the term disorder has been removed from the International Classification of Diseases of the World Health Organization, currently in its 11th edition. So similarly, homosexuality until 1990 was considered to be a medical disorder. After 1990, it is not considered a medical disorder or a psychosexual disorder. But however, many parents and even many doctors do think of LGBT people as being disordered, which is why there are many unethical practices still prevailing, where a parent will take a gender non-conforming child to a doctor and says, "My doctor, my child is abnormal, please cure my child." And the doctor, even though the doctor knows that there's no cure, it's not a disease, the doctor may say, "Okay, I'll cure your child, give me 50,000 bucks, give me 1 lakh rupees, etc." And they'll give shock therapy or something like that. And Kerala and Madras High Courts in the last 2 years have banned such what we call conversion therapy. And now the National Medical Commission has made it a rule across the country that if any MBBS or MD doctor promises to change the gender or sexuality against what the child wants or the adult wants, this is considered to be a professional misconduct, and the doctor can lose their license. Now, if a person is having gender dysphoria, that is, not only are they expressing themselves differently, but they are really wanting to change their body, before they go for surgery or before they go to meet an endocrinologist for hormone therapy, they need to get a certificate from a psychiatrist who looks at this person through questions, assesses whether they are transgender or not. This is not a physical condition. There is no chromosomal test or anything or a hormonal test which will tell you if a person is transgender. It's a state of mind which a psychiatrist can assess. And based on the letter given by the psychiatrist, which says the person is having gender dysphoria or gender incongruence, the person can then take this letter to an endocrinologist and ask for hormone therapy. And in India, you have to be at least 18 years old for that. Or for surgery also, you have to be at least 18 years old, unless you have very supportive parents who sign the consent letter for you. Now, what we have mentioned here is in the last bullet point, gender dysphoria diagnosis. I put diagnosis in quotes because it's not really a disease anymore. But to certify that somebody is gender dysphoric, the psychiatrist has to rule out other psychiatric conditions like schizophrenia. So there may be a person who is assigned male at birth who thinks they are Queen of England or Indira Gandhi or something because of delusions. So the psychiatrist has to rule out that the person's gender is not because of their perceived gender, is not because of a morbidity like schizophrenia or delusional disorder. It's because of their gender dysphoria. So such a certification is needed from a psychiatrist before a transgender person can start going on hormone therapy or go for surgery. Somebody raised their hand right now. Do you want to ask a question? Isha Bista, please go ahead. I can't hear you.
Isha, if you're trying to communicate something, you're muted.
Okay, maybe what I'll do is I'll come back to Isha's question because I can't hear it right now. I will, once I stop sharing, maybe the audio will improve. So we can just, Isha, hold on to your question, okay? You can ask your question later. So far I have talked about sexual orientation, whom one is attracted to, sexual behavior and sexual identity. Then we've talked about transgender, cisgender. We talked about the term assigned gender and gender identity. And we also talked about gender expression and non-conforming gender expression. And finally, we talked about gender dysphoria. Now, okay. Now I'm getting to talking about sex, okay? Biological sex, not the act of having sex. So sex is referring to the biological makeup of a person. And typically when the doctor delivers the baby, if the doctor has a penis and scrotum, the doctor will say this is male. If the baby has a vulva with, labia and clitoris and all of that, they'll say it's a girl. So this is based on external body parts. But if you look at the child from a genetic perspective, a child who has sex chromosomes X and Y is said to be male. A child with sex chromosomes X and X is said to be female. Similarly, as an adult, a male will have a higher proportion of the male hormones, which we call androgens, a specific example being testosterone, than the proportion of estrogen or female hormone. Similarly, a female will have more estrogens than androgens. So depending on whether you're looking at the chromosomes or you're looking at the hormones or you're looking at the internal body parts like a prostate or uterus or ovaries or fallopian tube, you will say this person is male or a female. So there are some assumptions here. You're assuming that a person with chromosomal makeup of XX is going to grow up to be a female, is going to have more estrogens than androgens as an adult, is going to have a vagina, cervix, ovaries, fallopian tubes, uterus, etc. Similarly, a child born with XY chromosomal makeup is at and after adolescence going to have more androgens, will be born with a penis and testes, etc., etc. But this correspondence between chromosomes and hormones and anatomy and morphology is not always 100%. So, for example, you may have a child who is born with XY chromosomes, but who looks female. So, in fact, there is a condition called androgen insensitivity syndrome. And you can see these 6 different types of external genitalia, starting with completely female looking to completely male looking. So all of these are different gradations of a particular intersex condition called androgen insensitivity syndrome, in which the child is born with XY chromosomes, but during fetal development, the body does not respond to the male hormones. Okay, so the child grows up. If the body does not respond at all to the male hormones, the child is born with completely female-looking phenotype. If it's only partial response, you may see a mixture of genitalia where you're not sure whether it's a clitoris or a penis. It may look partially like a scrotum, partially like the lips, the labia. So here are some photographs of intersex infants with the particular condition called androgen insensitivity, where it looks intermediate between a penis and a clitoris, or intermediate between a scrotum and vaginal lips, etc. So what I'm saying is that this assumption that we make, that chromosomes correspond to hormonal makeup, which will correspond to internal body parts and external body parts, is not always a correct assumption. And almost 1 in 100 infants is born to have some intersex variation. Now, there are intersex variations that are associated with sex chromosomes. So instead of XX or XY, you may have a child born with 2 X's and a Y, or a child may be born only with 1 X chromosome. Those are chromosomal variations, which are one type of intersex conditions. Now, there are almost 23 or 24 types of intersex conditions, and nearly 1 in 100, based on current systematic reviews, of people are born with either external or internal body parts that do not match up with the male and female binary. Okay, so people who are born with such conditions are sometimes born where the genitals are ambiguous at birth. Sometimes the child may not have ambiguous genitals. So looking at the first drawing on the left, on the right column, but leftmost, which looks completely female, such a child may be raised as a girl until 12 or 13, when the child does not start to menstruate, does not develop breasts. So then parents may get worried and take the child to a doctor. The doctor may order a karyotyping test and find out that the child actually has XY chromosomes, but has androgen insensitivity syndrome. So it is not the case that all intersex variations are evident at birth. Some of them are only evident at puberty, and sometimes they're not even evident. There are, for example, some doctor, a gynecologist in Kolkata was telling me about a woman who was brought to the gynecologist because she was unable to conceive. So externally, her phenotype was completely female, and she had gotten married, and she was also having sexual intercourse with her husband willingly, but she was unable to conceive, to get pregnant. So then they did some tests and found that the person was actually intersex and had internal testes. But the problem is, if they told this to the woman and the in-laws and the husband, it was quite likely that the in-laws would kick her out of the house or get the man to divorce her. So they had to be very cautious, and they did not actually disclose that she has an intersex condition. They just said that, she is unable to conceive, so maybe you should try a different thing like surrogacy or adoption. So sometimes an intersex variation is only evident later on in life. So these are about sex and sex characteristics. Before this, we talked about gender, gender identity. And before that, we talked about sexual orientation, behavior, etc. So what is common to all of this? These are definitely very different, very, types of diversity. One is about who you're attracted to. Another is about whether you feel like a man or a woman or both or neither. And another is about your body parts. But what is common is, in society, we expect persons to be a certain way. You expect boys to grow up to be men, to be manly, to be attracted to women, to have children. You expect a woman to have XX body parts, to be capable of reproduction, to have children, get married, all of that. So anybody who does not fit in these boxes, for whatever reason, faces some disapproval or harassment or teasing or bullying or violence. So very often you have people saying that, oh, all of this LGBT stuff is not found in our culture. But actually, there are quite a few examples. If you look at Indian sculptures or Hindu sculptures from the Himalayas, from Khajuraho, from Konarak, even if you look at certain indigenous communities, like this is an indigenous Manipuri community, where a child who's trans is considered to be a gift from God, and the child is very much respected within the family, is often, assigned to work as a shaman, in terms of calling, etc. So there are many examples. For example, you have the Ardhanarishwara image of Shiva as half male, half female. So there are many examples in our culture, or particularly in Hindu culture or pre-colonial non-Hindu cultures, that talk about people of different genders or people of different sexual orientations or sexual behaviors. Of course, we don't know what's in the mind of a stone sculpture. All we can say here is a man performing oral sex on another woman, on another man, or 4 women having a sexual orgy together. So we cannot infer the sexual orientation of these people, but looking at the behavior or looking at the phenotype, we say these people are diverse. So even within the medical community, even though in 1990 itself, the World Health Organization said being gay, lesbian, bisexual is not a disorder, the MBBS and MD textbooks in India print a lot of outdated information, and you will still have allopathic doctors to this day saying gay, lesbian, bisexual is a disorder, or being transgender is a disorder. And another thing they will say is that this is not natural, this is unnatural. But if you talk about nature, human beings are just one of millions of species. And in over 450 species, including mammals, reptiles, fish, birds, and insects, we see pairs of two males or two females. We have individuals that actually look externally male but are internally female, etc., etc. And we scientists, biologists, behavioral scientists have documented this in chimpanzees and swans and dolphins and penguins and a number of species. So the argument that this is not found in nature or this is unnatural is also false. The argument that this is against our culture is also false, because we see a lot of examples. So what really is the problem? The problem is that society and family imply that man marrying woman, woman marrying man, man attracted to woman, woman getting attracted to man, getting married, having children is the way, and anybody who does not fit into this is an outcast. And a child who is gender non-conforming faces bullying from other children. A lot of case studies we have are where the teachers themselves sexually harass the children who are gender non-conforming. All of this can lead to a lot of mental health issues and manifest into in thoughts of suicide, etc. And as I mentioned, that even within the medical community and in some religious communities, there are practices to try and change a gay child to a heterosexual child, or a trans child to a cis child. So speaking specifically about mental health and SOGIESC. So SOGIESC is a term where SO is sexual orientation, GIE is gender identity and expression, and SC is sex characteristics. So anybody who's of a minority SOGIESC, that's a minority sexual orientation, like gay, lesbian, bisexual, asexual, minority gender identity, like transgender or non-binary, minority gender expression, like a feminine male or a masculine female, or a minority sex characteristics, like an intersex person. All of these people face the teasing, the bullying, the prejudice, which leads to low self-esteem, depression, anxiety, eating disorders, substance abuse, self-harm, suicidality, other mental health problems. And if you're talking about people right now who need palliative care and who grew up in a time when these issues were not talked about at all, just the burden of keeping their identity secret and private to themselves and fearing getting found out by others has a huge psychological impact. And it may not, people may not know, people may say, okay, she's crazy, she didn't get married to anybody else, maybe she has a mental problem, maybe she has a physical problem. The problem could really be just the problem resulting from a disapproving society. We have data here, quantitative data. The top right is about boys who are gay or bisexual, compared with boys who are not gay or bisexual. Similarly, girls who are lesbian or bisexual, contrasted with girls who are not lesbian or bisexual. We are looking at two variables here, thinking about suicide and attempting suicide. And in both cases, we have higher rates of suicidal ideation and suicidal attempts among people who are gay, lesbian, or bisexual versus those who are not, when we look at the adolescent age group. If we look at transgender, this is a data set of about 6,450 individuals in the US. We have 47% have attempted suicide. And if you look at the reasons or putative reasons, 57% were rejected by families, 19% were refused medical care, 19% have experienced homelessness, 41% are not able to change their gender on their identities. In some ways, India is more progressive than other countries where there is a more recognition of at least some transgender people, particularly the Hijra community. I won't say there's 100% acceptance, but there are some supportive laws where being a transgender person, you still have rights and you can actually legally change your name and gender. So when we talk about, the point I want to make is that LGBTIQ people face a lot of mental health issues because of the disapproval of society. Yeah. Now I want to talk specifically about children, and in this context, I'm going to share with you a video. Someone has their mute off. Can you mute, please? Okay, thank you. Thanks. So the violence that gender non-conforming children or children who are gay or lesbian or bisexual may face in school include verbal teasing, like teasing a child saying you're a hijra or a chakka. There can be physical, beating up such children. There can be the emotional violence, like the teacher saying, don't sit here, don't sit with the boys or girls, go and sit in the middle. And there can also be sexual violence, where a child who's gender non-conforming, very often such children have, reported in studies that they fear going to the restroom, because in the restroom is where a lot of bullying takes place. They are forced to, expose their genitals to other children, all of that. So all of these leads to psychosocial outcomes like feeling isolated, feeling that they don't belong, feeling anxious and depressed, feeling like taking their life by suicide. When you look at educational outcomes, you see a fall in grades. The child no longer has the ambition to, complete 10th or complete 12th, go to college, etc. There's increased absenteeism and increased dropouts. Now, people in the field of educational psychology in India who have studied dropouts, and some of this is also reflected in the national education policy, they have mostly focused on other reasons. So a child who is particularly dark-skinned and is assumed to come from a marginalized caste, or a child who's from a minority religion in a class where everybody else is of a majority religion, or a child from a very economically depressed family where they are not able to buy new clothes and the child comes wearing tattered clothes or worn out shoes, etc. Or the child does not speak the local language, the child has come from somewhere else. All of these can be causes of bullying. But one important cause of bullying that only now people are starting to research in the Indian context is the child's gender expression or sexual orientation is not what is expected. So we have a study that we did with about 13,000 transgender adults. About 27% of them had dropped out of school by 5th grade. And most of them dropped out because they couldn't stand the teasing and bullying. And sometimes they can't even go home and talk about the teasing or bullying, because the parents will say it's only because of you that you're facing this bullying. So why don't you try and act like a boy or act like a girl, depending on the gender. So in the very worst case scenario, children, particularly children who are assigned male at birth, who identify themselves as not male, run away from home and join the Hijra community. So the Hijra community is largely comprised of kids or young people who've run away from home, where the home and school have not accepted them or have harassed them, and the only safe place they get is within the Hijra community. Unfortunately, if they are deprived of education, the only livelihood means available for them is sex work or begging. And now this is changing. There are a lot of government schemes for people who have not finished school to actually go back and do vocational training, etc. But we need to do a lot more work for getting people back into the mainstream. Very briefly, what does the law say? Since September 2018, it is no longer a crime to be in a same-sex relationship. So about 200 plus years ago, India inherited the penal code from England, and one of the Indian penal code sections was called section 377, which basically said that if two people have sex other than penis in vagina type of sex, it could be oral sex, it could be anal sex, it could be sex between two men, etc. All of this is a crime. And only in 2018 did the Supreme Court change this to say that if you're two people and you're adults and you're consensually in a relationship with each other or consensually having sex with each other, then it's no longer a crime. So now the law of the land says that two people who are men or two people who are women can live together in a relationship, even though marriage is not recognized, it's not a crime. Okay. And since 2014, transgender people have protection under the law. So these are two Supreme Court judgments. The 2018 judgment is called the Navte Johar judgment, and the 2014 judgment is called the NALSA judgment. NALSA stands for National Legal Services Authority. Okay. So, okay. Now I'm going to talk a little bit about conversion therapy, because can I see a show of hands of how many people actually have a mental health background, psychiatry or sociology, psychology or counseling or social work? Can we see a show of hands of how many people have that background? Yeah. 1, 2, 3, 4 participants raised their hand. 5 raised their hand. Okay. So I think many of these fields, as I said, the textbooks have not really changed. And but we have a few people from the psychiatric community. This is Dr. Jacob, who is the head of the Department of Psychiatry at Christian Medical College, Vellore, Tamil Nadu, who as early as nearly 13 years ago, has been writing in many of the psychiatry journals saying, writing to the fellow psychiatrists saying, do not attempt to change the sexual orientation of people. Leave it like that. Trying to change will do more harm than good. Okay. And then in 2021, Madras High Court and actually now the Kerala High Court have also banned conversion therapy, and practicing conversion therapy is grounds for revoking the license of mental health providers, including medical professionals. So whether you're a psychiatrist or andrologist or sexologist, or any person that had an MBBS degree, doing conversion therapy is banned. However, the Rehabilitation Council of India and the other professional association for counselors and psychologists have not yet banned it. They have issued statements saying we do not approve of conversion therapy, but they have not banned it yet. Also, National Medical Commission has classified conversion therapy by allopathic medical professionals as professional misconduct, and they have notified all state medical councils as of August 2022. That's just 4 or 5 months ago. Somebody raised their hand. Do you want to ask a question?
Sir, actually, I was about to say the same thing. I think you have already mentioned, I mean, just the medical, I mean, the RCA, the MPhil community also regarding that already. I think I was about to tell that.
No.
I think you have already mentioned, so that's it, sir.
Okay, okay, good. Yeah, we can discuss this more when we get to the discussion. I'm just going to do a quick time check. We are 3:58. I have time till 4:30, right?
Yes, sir. We don't have a case presentation, so yes,
Yeah,
we
okay,
have time till 4:30, including the discussion.
including discussion. Okay, fine. So now let's bring the lens to looking at palliative care and what are the barriers to accessing palliative care. Whenever we talk about palliative care, we talk about, the support that people can get from their families, support people can get from institutions, and the need for support from, let's say, a caseworker who comes and visits and provides some amount of palliative care and medication if needed, etc., etc. Now, a lot of people from the LGBTIQ community, especially from the older generation who are transgender, have completely been estranged from their natal families, meaning they've run out of home, or they ran away from home because otherwise they would be forced to get married, all of that. Some of them, of course, have been forced to get married and then have run away from home. We know of many people who are in their 30s or 40s who got married, had kids, and then ran away from home because they couldn't take that life anymore, but they didn't come out and disclose to any of their family members that they are gay or lesbian, right? So the birth families as a source of palliative care support may very well be absent for people who are elderly and who need palliative care, or people who are dealing with an end-of-life situation. Also, a person may have a partner, a spouse who's of the same gender, not legally recognized, but there may be a woman who's 65 years old who has been living with another woman for many, many years. She only refers to her as her friend because nobody else would question her if she just says friend. I mean, though eyebrows may be raised, there's still not the legal possibility of marrying another woman. So the entire family may completely choose to ignore the fact that she has a partner. So if there is, for example, a health-related decision to be made, and there have been examples of this even during COVID, where there's a couple that I know, both of them were men in their 30s, and their parents absolutely refused to recognize their relationship. And one of them had to be put in critical care, and then they needed someone to sign on, and they refused to accept the boyfriend as a next of kin or as somebody who's capable of making those decisions. and the parents also were not accepting. So there are some very difficult situations in the palliative care context where the parents are also not approving, and the partner is also not recognized by the society or by the healthcare system. And there is a history of hostility and indifference within healthcare settings. So even now we hear people who go to the doctor. If a woman goes to a doctor, let's say she goes to a gynecologist, the first question the doctor will ask is, are you married? Because are you married? And the answer to that is supposed to tell the doctor all she needs to know about her sexual exposure, her sexual interaction, her having children, not having children, etc., etc. So a person who is not attracted to man, and she's a lesbian, but she does have sex, but she doesn't have sex with a man. The kind of questioning that goes on in the OBGYN setting doesn't even leave room to talk about a different sexuality, right? So the doctors and the care providers, including palliative care providers, have all these assumptions that a person is heterosexual, a person is cisgender and not transgender, all of this. So all of these cause barriers to accessing palliative care. So some of the best practices that have been published in the last 4 or 5 years, I just take a minute to read this and I'll come back and explain this. So the first one, in fact, can someone volunteer to read this point? Just go ahead, unmute and read it out. Anyone? The gentleman who just spoke right now? Yeah. Can someone read out, please?
I could read if nobody else is volunteering.
Go ahead.
Invite and allow disclosure of sexual orientation, gender identity, and sex characteristics in a safe and comfortable space. Sorry about the barking dog. Should I continue to read or someone
Please
else?
go ahead, yeah.
Utilizing respectful and sensitive ways to elicit SOGI information allows for an organic conversation and relationship to evolve. Do not assume based on appearances or behavior. These actions result in greater comfort level, higher overall healthcare satisfaction rates, improved patient caregiver provider alignment, better sense of well-being, and enhanced quality of care for the LGBTQ patients and their caregivers.
Okay, so this is from a journal of oncological nursing, where they may be dealing with people needing palliative care even at a younger age. Yeah, thank you. Was it Shruti who read it out just now? Yeah, okay, thanks. So what is SOGI? SOGI is sexual orientation and gender identity. In this paper, they have not talked about intersex. So they've only talked about LGBT, cancer survivors. So if the person is there and the relatives are also there, it may not be a safe space for the palliative care provider to ask the person, oh, are you lesbian? Are you gay? Right? Because the person may not want to disclose in front of their natal family, or for that matter, the marital family. So find a way, and some of the ways in which people have done it is, if the person is, let's say, single, and you want to elicit some responses regarding whether they have a relationship with somebody of the same gender, you first make the person feel comfortable. You don't jump into the sexual orientation question, but we can ask, like, have you been single all your life? Is there somebody special in your life, or was there somebody special in your life? And people are of all different types of people. There are people who have very close friends of the same gender. There are people who are friends of another gender that they do not get married to. All of this is fine. We're not here to judge, but we want to know if there is somebody in your life who is important to you, whom we should involve in your care. So something like that we can ask. And so this is one of the best practices that came out. This is another from the same article, I think. Yeah, same article. Understand the lived experiences of LGBTQ patients through their experiences of multiple external and internal stressors, implicit and explicit bias, oppressive and discriminatory encounters, and destructive healthcare systems. Inquire about existing families of choice, relationship partners who are not recognized by law, and explore how they can be included in the provision of care, including advanced care planning. Now, in India, the only legal provision we have for partners who are not blood relatives or legally married spouses comes from the Mental Health Care Act of 2017, where an individual with a mental health condition is allowed to designate someone who could be a friend, who could be a same gender partner, who could be anybody who is not a blood relative or a legally married spouse, to make the care decisions about them. So as of now, the Mental Health Care Act is the only law that we have, and it's only in the case of people with mental health conditions. And lawyers and activists around the country are trying to bring similar provisions for other areas of healthcare, but that's still, in the very early stage. So I just wanted to speak a little more about experiences in healthcare settings. Very often, if a transgender person goes, and this happens to this day, to a clinic in a hospital, especially in a large hospital setting, even without taking the client's consent, the doctor will turn that opportunity into a teaching session for their interns and PG students, ask that person to take off their clothes, invite all the students and PGs to come around and observe. So it becomes really, really humiliating. So because of experiences like this, an individual who is an older individual or someone who's in need of palliative care may hesitate to even speak about being transgender for fear of eliciting, stigma and discrimination or just insensitive treatment. So a lot of people from the LGBT community who have survived a lifetime of stigma and discrimination from family, from school settings, from their workplace, etc., may get really triggered if the questions appear to be insensitive, or they fear that answering the question will expose them to more prejudice. So one has to be really sensitive about all of these. Okay, here, this is about a different paper from 2021, which is about physical examination. Sometime you may need to do a physical examination. So the physical examination component of a palliative care encounter starts with showing respect by obtaining permission to proceed with the exam and allow the patient to take the lead based on the patient's comfort level. So if the individual is transgender or gender non-conforming individuals, they may have a lot of shame associated with their body parts, especially if they belong to a generation or an economic status where having surgery was not possible for them. So a trans woman may actually still have a penis, may not have been able to afford to go to a surgeon and construct a vagina, which is the vaginoplasty surgery. So asking her to expose her genitals may bring about with it a lot of shame. So there are ways in which, ideally, if we have a mock session, we should be able to figure out ways in which we can ask questions that are respectful, that do not make the person even more anxious. Openly discuss the purpose of doing the examination. So say that I'm doing this examination just to see if you have any urinary infection that is, or some other infection on your genitals, which is, sorry, I take back the urinary infection part. If you have some infection in your genitals that is visible. So, you explain why you want to do that kind of physical examination, or I want to know if you have developed, bed sores in your buttock area, something like that. So do it by explaining the rationale. And you can also ask the patients to teach providers about naming an anatomic parts. People may have shame in actually saying this is my penis if they are very strongly gender dysphoric and identify as a woman. Okay, so there are people do have coined terms for their own body parts. So you ask them what you refer to this. So they may want to refer to their breast as a chest, or their chest as a breast, things like that. And the significance of respectful touch will foster trust and build rapport. Okay, so that is the presentation part of it. It is 4:10. We have 20 minutes, plenty of time for discussion. So I'm sure that there are questions that you have. I'll be sharing this PowerPoint with the organizers so you can refer to the slides and to the references. Yeah. Okay, here we go. Questions, comments, maybe first feedback. We see that there are 67 people here. I'm able to look at you all just now, those who have their camera on. So any feedback on the session from how it made you feel? Did you feel that this is all information that you knew about and is therefore boring to you? Is there something that's very new? Is there something that runs counter to your religious or cultural beliefs, etc.? So please do share. Yeah.
Yeah, hello, I'm from Nepal
Okay.
and
Hi.
I work as a clinical
Your name?
psychologist.
Yeah.
My name is Isha Bista.
Okay. Hi. Yeah.
And this generation of kids that I'm working with, not all of them, of course, but many of them are very open about their sexuality and things like that. Like sometimes when I ask them, they'll say things like, yeah, I'm still choosing, I haven't decided yet.
Okay.
Or maybe I'm not sure yet. And it's very nice for me to hear children saying things like that, because my generation of people from the LGBTQ family, they have a lot of struggles and a lot of problems internally and with their families.
Right. Right.
But if there's so many people, in the same boat, I think next generation will be very accepting, and it's very nice to hear that.
Yeah, absolutely. And I think Nepal is also a country where there are legal protections. I think even much before India, Nepal recognized transgender people and so on. So it is also an environment in a society where it may be a little more safer than some other country, right? So, but that's great to know you've had this experience. Yeah.
Yeah, safer, I'm not very sure, because I live in Kathmandu and not all children are like that. Most families, including mine, maybe my parents are open, but a lot of my family members, extended family members, are not open to it.
Okay.
So safe-wise, maybe not, but then the next generation, I'm very hopeful for the next generation.
Lovely. Great to hear. Thanks. Yeah. And then since you shared your experiences, have you worked in a palliative care context before with LGBTQ people?
No, I haven't.
Okay.
But mental health issues, yes.
Okay. Okay. And what were the kinds of mental health issues that came to you?
Depression, anxiety.
Okay. Okay.
Deliberate self-harm.
Okay. Okay. Okay.
Yeah, but then that would be under depression usually. So.
Yeah. 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 Okay. Great. Thanks. That's really nice to know that you're an affirming provider and you've had people who are comfortable to come up to you and open up. That's really important.
No.
Anyone else would like to just share their reflection?
Sir, I am again. The
Yeah.
information was very effective and good, new to me.
Okay.
It is very new to me and appropriate in the case of palliative care. I even think about the physically enabled persons. What about the criteria for observation and inspection?
Right. Correct. Correct. Absolutely true. Yeah. Yeah. So basically you're saying that this physical examination is an issue not only with LGBTIQ people, but could also be an issue for persons with disability, right? That's what you're saying. If I understood.
Yes.
Thank you. Yeah. 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 Thanks.
I have another question.
Yeah.
Where do they do gender changing surgery? How much would it cost?
Where are you asking about?
Where in India? Isha again. Where in India? Because I do tell.
Okay. Got it. Got it. Yeah. So in India, there are a couple of states, Tamil Nadu and Chhattisgarh, and Orissa, where you can get the gender affirming surgery done free of cost in the government hospital, but there are waiting lists running up to almost 1 year. In the state of Kerala, you can get the surgery done in a private sector hospital, and there are 2 or 3 private sector hospitals in Kerala, and it can be reimbursed up to 5 lakh by the government of Kerala. If you look at other parts of India,
then for being an international person,
okay, for being
we
an
don't get the
international
free
person,
services and
okay, yeah, you can't get free services, but there are some relatively low cost services. So there are a couple of charity hospitals. They are private hospitals, but they are charity hospitals in Tamil Nadu and Pondicherry that if you want to ping me later, I can share with you and I can introduce the person to the doctor if necessary. But closest to Kathmandu would be Delhi, where there are 2 or 3 private hospitals where you can get the surgery done. But it will be expensive, meaning in Indian rupees, it may still be 2 or 3 lakhs or even more. And if the surgery is just, if it's a trans man who just wants a mastectomy, that may be cheaper. It may be under 1 lakh. But if you want, for example, hysterectomy as well, or if you are a trans woman and you want vaginoplasty, or if you want breast implants, all of that may set you back by 4 or 5 lakhs in Indian rupees. But yes, there is an online list of crowdsourced list of surgeons and hormone specialists who are friendly to the community, and I can share with you that information. If you can ping me later in the chat, I'm going to just give my email address. Also, like somebody posted, Thailand is the go-to place where many people across the world do go for surgeries. People from Europe, people from India who can afford it, do go to surgery in Thailand. So that's also an option. Yeah.
Thailand will be very expensive.
Yeah, it's expensive, but it's cheaper than getting it done in the US, for example, or Germany.
Yeah.
Yeah. But remember, the trans people are only, like, if you look at the LGBTIQ spectrum, the smallest fraction would be intersex. The next fraction would be trans men. The next would be trans women. And then I think gay, lesbian, bisexual people would be much more. So what I'm trying to say is that you are probably more likely to encounter somebody who's gay, lesbian, or bisexual and not necessarily know it. So as they say in history taking, don't assume anything. Even if that person, appears to be cisgender, don't make any assumptions. So the issue around history taking and asking people for their pronouns, if that is appropriate, would be something that you could practice with everybody. Yeah.
And I think with children, you can ask straightforward. They don't really mind if you ask them. They'll say yes or no, and that's it.
Yeah, but can you ask a child in the absence of the parents?
Yeah. Actually, they disclose it in the absence. Children as an adolescence, they disclose it in the absence of the parents. So.
Okay, adolescents, yes, but if it's a younger child, you may not be able to.
A younger child, it doesn't usually come up. One thing that I was tempted to say when you were going on was sometimes children don't have a male or female role models. A boy may be raised only with their mom and sisters and might have a feminine behavior because of lack of role model. So you have to always look at that aspect also when you work with children.
Yes, very true. The gender may be gender non-conforming for other reasons, but the point is no intervention should be attempted. Let the child grow as they please and make sure that the school and home are safe places for the child. Because otherwise, trying to say if the child is like this for some reason, some behavioral reason, some psychological reason, can end up causing trauma. So
yeah, and they're so sensitive about it. Like I had a transgender woman, and the mom was supportive. The father never came for therapy, and they came to make the child male again because his sex organs were male. And we used to keep telling the mother it's not like that. And the psychiatrist she'd gone to before me called her a him. And she never went back to my friend, because she looked like a male a little bit. And then she never went back. So you have to be very careful. And she also told me that the happiest day of her life was when she was able to wear a wig on a weekend and then go out with her friends. And, they're very nice stories, actually, if you listen to it. And what they did and how free she felt and all that. It's very nice to, when they share stories like that. Anyways, that defeats the purpose of the scope of today's training, but even then.
Hello, sir.
Sir, you are muted, Ramakrishnan, sir. Ramakrishnan sir, if you
Sorry, I was on mute. I was saying that we'll take the questions, and the link I've pasted in the chat. You can watch this video later. It's about like a young child who's transgender, who has gender dysphoria. You can watch that later. But now can we get the question from the two people who have raised their hand? One is, I'm not sure if I'm pronouncing your name. I apologize. Shatavisa Majumdar. Please unmute yourself.
Good afternoon. It was a very wonderful session. I am practicing as a clinical psychologist, and I also provide queer affirmative psychotherapy to the clients. One thing I have observed very often in the hospital settings is one is mispronouncing a person and calling them sir or ma'am, just looking at their gender expression. And another thing is no access to gender neutral toilets.
Right.
That is a very big issue. And especially in hospitals, like when some transgender person is coming to get admitted, they have some problem in deciding where to keep that transgender person in which ward they can keep the transgender person. And general lack of awareness about, like, many people don't even know that why the pronouns are important and how it is making any difference.
Right.
And one question I have for you is that I have done psychological assessments for gender reassignment surgery before. But as there is a guideline, standard of care, WPATH, which is used in other countries. Is there any such guidelines available in our country, which we, the mental health professionals, can follow? That is my question.
Okay. That's your only question? Yeah. Okay.
Yes.
So I'll come back and answer your question right now. Somebody else had their hand up. So if I can take that question as well and answer both together. Did someone else have a question?
Ravikant, you are muted if you are trying to do.
Sir.
Yeah.
I'm a psychologist from Visakhapatnam.
Okay.
So generally, right now, I mean, there is no clients, I mean, especially the LGBTQ, but thing is, any do's and don'ts, any manuals are there to better address the concerns of LGBTQ, or any training programs or any counseling therapies we can use?
Sure. Okay. So both these questions are about references and manuals and guidelines. Now, okay, to the second gentleman, Ravikant, to the second person, I actually have a paper written for mental health professionals on what you should know about providing mental health care to the LGBT community. It was written just before the Supreme Court verdict of 2018. So just one part of it has to be updated, but I'm happy to send the PDF if you want to email me or WhatsApp me. And
Okay.
yeah, so that's there. Then apart from that, there are some guidelines. So Sappho for Equality, which is a group based out of Kolkata, lesbian, bisexual women and trans masculine persons. They have put together a compendium of good practices in providing gender affirming care. It primarily focuses on mental health rather than endocrinology or surgery, but that is there. It is there on the sapphokolkata.in website. I think that's, if otherwise you can search for it on Google. Apart from that, the WPATH guidelines that you mentioned, there is right now, Standards of Care 7 has got replaced by Standards of Care 8. So you can look at that. You can also Google IPATH, which is Indian Professional Association for Transgender Health, which is basically a group of doctors in India who are transgender affirmative. It was started by an army doctor who is the father of a transgender girl, Dr. Sanjay Sharma. So you can Google IPATH and you'll find IPATH Standards of Care 1, which is right now being revised too. So I'm going to put that all here for you to look at. So IPATH SOC, WPATH SOC 7, Sappho, and then the paper that I have reference is by first author, Dr. Patnaik et al. This is Dr. Amrit sorry, not Patnaik, Patajoshi, sorry. Yeah, P-A-T-T-O Joshi, yeah. So I'll, if you want any of this, just ping me and I'll be happy to share. It's 4:25, so we maybe have time for Dr. Chandrasekharan. You have raised your hand. Please go ahead.
Good afternoon, sir.
Good afternoon.
I am from Bangalore. I am a practicing psychiatrist and psychologist as well.
Okay.
Yeah. So just one question about that case study that you mentioned. She got married and they could not identify.
Yeah.
Was there any checkup on whether she was having a regular menstrual cycles or anything like that?
So I don't know the full case. It was just mentioned to me by a person who is a gynecologist. I don't know the full thing, whether it was, the person did not have amenorrhea. Okay. The person did not have amenorrhea, but they did have some issue that, and they had some tissue that had, testicular streaks or something like that, or ovarian streaks. I don't know the exact situation. Yeah.
Okay. And I do see, a lot of now young girls, they are definitely like, more of female, but habits and, the behavior is more like men. They cultivate all substance abuse, and the most cases, the parents themselves are subduing the child not to disclose. So there is actually no way a psychiatrist can identify whether it is really LGBTQ or gender dysphoria, whatever.
Yeah.
We just have to treat them for schizophrenia, this, on a superficial thing.
Yeah. But doctor, in the context of diagnosis, there is the whole informed consent model that the world is moving towards, and WPATH also mentions this, that if an individual comes seeking, let's say, a gender reassignment surgery or a hormone therapy, as long as you are able to rule out a morbidity like, schizophrenia, and as long as you assess the client to be adult and fit to make up their own mind and make decisions regarding their bodies, they should be allowed to do it. That's the informed consent model that I believe everyone's moving towards. So yes, it is true, being transgender is and even the law has said this, it's not an external diagnosis. It's for the patient to identify and for the patient to share. But yes, if you have to assess as a psychiatrist and give a letter for somebody who wants to go on hormone therapy or surgery, as long as you are able to assess that the person is, of quote unquote sound mind and able to make their decisions, the bodily autonomy is theirs. So as long as that is given, it should be okay. So we work here with doctors like Dr. Hema Tharoor in Apollo here, and Dr. Shiva Prakash at the Schizophrenia Research Foundation. So all of them have moved towards this informed consent model. So basically, make sure the person is validating their own gender. Don't look for corroborative evidence based on their sexual orientation, because a trans woman may be attracted to women as well. So that's not a rule for excluding or including. Just elicit their history of gender incongruence, rule out things like schizophrenia. And if they are affirming their gender as something different from the assigned gender, then that should be sufficient. And if you like, I can share some more published literature on this model. Thank you.
Please,
yeah.
sir. Please, yes, it will be nice. Thank you so much.
Yeah, sure.
Thank you, sir. Thank you.
So I think we are out of time, unless someone has any closing comments, remarks, questions.
Dr. Ramakrishnan, I think we have one query in the chat from Saima Khan, who wants to know whether there are any helpline in India for this community, LGBT community.
Good question. So there is one helpline called, it's from the Tata Institute of Social Sciences. I think it's called I Help. Or does anyone know the full name? I think it is. It's a free helpline, but it's not 24/7. And they speak multiple languages. They have counselors speaking multiple languages, and they are LGBTIQ affirmative. So I often refer people who seek professional services, but are not in a place to go and visit or pay for a professional, to contact that TIS helpline. Let me just see. It is called iCall, sorry. iCall. So I'll just type it here and you can go to Google and you can get it. Yeah.
Doctor, one last information I need, please.
Yeah.
I just want, we have a palliative care unit in Bangalore. Generally, it is surprising in spite of so much knowledge and, information. No doctor has ever seen a real LGBTQ case, or, we have never got a case as a referral to take care, palliative care or end of life care. I just want to know where, if we can probably put our address and, if we can be of some service. Is there any link like that or something?
Yes, first of all, thank you very much for thinking about that. There are 2 or 3 online websites, 2 or 3 websites that have online directories of LGBTIQ affirming lawyers, psychiatrists, different kinds of service providers. And I don't think we have palliative care providers as yet. So we would love to maybe have a conversation with you. Sati has one of these, it's actually based out of a website called, let me paste the link there, vartagensex.org. So if you go to this website, you'll find an online directory, searchable directory, and you can go and fill in a form nominating yourself in the area of palliative care. And there are a couple more. One is from a community group called orinum.net. So you can search by healthcare, orinum on, 1 second. And then there's a third, which is based out of Delhi. I don't remember the name. It's called Safe Access. Yeah. Yeah. So these are the 3 websites I know that have online directories. But doctor, if you are willing to publicize that you're available or that your team is available, it will also be a good idea to reach out to the 10 or 12 LGBT groups that are in Bangalore, like Swabhava, like Sangama, like Payana, like Rahi, and, let them know of your services. So if you can possibly email me, I can, get these groups in touch with you.
I will do that, sir. Thank you so much. Yes.
Sure, my pleasure. Okay, so should we close?
Sure, sir. I think great questions been answered, and after this conclusion too, there are so many questions and so many stigmas around our heads too. We have so much questions circling around. So it's a vast topic. We know that, and it's been clearly presented by you. I know you have a wonderful experience with LGBTQ persons and organizations and all. I hope your knowledge will be very useful for us in the coming sessions and coming periods of time. So thank you so much for joining. And if there are any questions arise, we will mail you through, and we will need your knowledge, actually.
Thank you. My pleasure, and all the best to the team. And thanks again for your interest. Bye.
Thank you, Dr. Ramakrishnan, for joining us. We do understand that you were having a busy day today. You were just back from another session and you joined us. And thank you for enlightening this cohort with your knowledge, your deep knowledge. And we do hope to have more sessions with you in future as well. So with the positive hope that everyone has got at least one takeaway from today's session, it will be very helpful. This is Sri Priya along with Dr. L. Ramakrishnan and Mr. Sharad signing off from the Tips Eco Hub. Everyone take care, stay safe, be happy. Bye-bye.